All right, welcome everyone to Grand Rounds. We'll get started here. I also want to thank our visiting resident applicants. So hopefully you've had a chance to enjoy our beautiful city and the interviews are going well. So this is our second CPC resident presented CPC case of the year. We're going to have another child neurology CPC later in the year. And today's case is going to be presented by our august chief residents, Annie Lynn and Paul Johnson, with our expert discussant. Dr. Van Geldern. So I'm going to let Paul take over and introduce Gloria, but enjoy the case.
Great. Thank you so much, Dr. Ransom. So as Dr. Ransom mentioned, this is a CPC, or clinical pathological correlate, where Annie and I will present a mystery case to Dr. Van Geldern, who's our master clinician. And Dr. Van Geldern does not know the case beforehand. And the point is not to present a case that's difficult or going to stump Dr. Van Geldern, but to see how a master clinician would think through a case. So Dr. Van Geldern is a faculty member here at the MS Center at UW. Dr. Van Geldern did a neurology residency both here at University of Washington and in Germany. She did a fellowship in neuroimmunology at Johns Hopkins, and then did a fellowship in neuroimmunology and neuroinfectious disease at the NIH. And she has varied research interests, including PML and HIV, effect on cognition, handedness and nutrition on MS, among other things. And we're very lucky to have her here at the Northwest MS Center and that we're able to work with her.
So where did you find the photo?
Yes, the photo is
That's not fair.
so courtesy of Dr. Wundus, our other MS attending at the MS Center. So we think you can thank Dr. Wundus for that.
Oh, okay.
And she was a former Alex Spence Award winner when she was a resident here. So
That's the clap for Alex Spence, I think.
Which is an award given for outstanding patient care and compassion. I want to welcome our applicants who are visiting here and interviewing tomorrow. So welcome and enjoy this grand rounds with us. We have no disclosures, and really I just needed an excuse to show a picture of my dog. So, so the case that will be presented today is actually somebody that I saw in my continuity clinic at the VA. This is a patient that was referred by his primary care doctor. And the patient's name is CP, and he is a 58-year-old right-handed man who was referred for gait problems. And he complained initially of a very slowly progressive difficulty with walking that had evolved somewhere over the last 2 or 3 years. He wasn't quite sure. And he just said that he felt somewhat unsteady, but he didn't complain of any sensory problems or weakness in the legs. He just felt like his walking wasn't quite right.
So as you're grabbing the microphones, our first question would be, so just based on what we know so far on this patient, which is a simple one-liner, what kind of general category disease will be on your mind, and what will you be start thinking about it when you see this patient?
Obviously, right now, this is still very wide differential diagnosis. Two things that you already mentioned in the last slide would be sort of important to think about. Is the gait problem because of sensory issues, because of weakness, or because of cerebellar issues, so sort of ataxia type problem? And a lot of that would probably depend on the physical exam. Sometimes it's actually really hard to, I think, get from history.
So, of course, we elucidated that history a little bit, and the patient had mentioned that he had, again, no definitive onset, but it seemed to be an insidious problem. He said that he was not falling, so he had, though, started to use a cane, but it hadn't progressed to the point where he felt like he was so unsteady that he was falling. And he actually thought that he had plateaued, and maybe over the last couple of months that there had been really no change at all in his gait. He did know that he often trips over small objects, so rugs, the sidewalk was uneven. That might give him difficulty. If there was like a garden hose lying in his path, that might give him problems as well. He also said that he would frequently feel like he might stumble backwards, take a couple steps backwards, especially like when standing up quickly, that he just felt like that was a particular weakness for him.
So based on what we know so far, before we move forward, is there any specific ideas that you have that you wanted to ask about past medical history and kind of family history that you would be interested in?
Yeah, so past medical history, I think because again, this is still very broad, it'd be interesting to know. Maybe I'm biased because you saw him at the VA to make sure what kind of vascular risk factors or past medical issues this patient has. Family history would be interesting. Any other family members who have trouble with walking? He's probably, I forget how old he was. He's probably a little bit old for most sort of inherited, but you can have milder forms of inherited problems as well. So that's a quick question to say, is anyone in the family have issues with walking? It's always important to get a little bit of social history background in terms of exposures or things like alcohol, but again, you would want to ask sort of more detailed questions, maybe based on some more exam as well.
Okay, and that's great. And he is 58 years old, so definitely a little bit older. Vascular risk factors included hypertension and hyperlipidemia, both which were fairly well controlled on medication. He also had a recent diagnosis of restless leg syndrome within the last year, which had been responsive to Sinemet. He also complained of low back pain of long duration, and he had undergone an MRI of the lumbar spine in 2012, which showed pretty typical degenerative changes, but nothing that was really a big red flag for us at that time.
Can I ask two more questions
Yes.
based on this? So first of all, with the levodopa, did his walking get better at all?
So he didn't think that the walking improved, just the restlessness in the
Because the
legs.
sort of standing up and sort of falling backwards could potentially put sort of Parkinsonian symptoms on the differential. Then the lower back pain would make me want to ask another question of does he feel that if he walks he gets pain and then he has to sort of sit down or bend forward or anything like that, sort of thinking about lumbar stenosis?
So he denied any symptom of claudication.
Dr. Oaks has a question.
Can we add other questions, Dr. Geldern, or
We certainly welcome any additional questions from the audience as well.
what about like a sexual history? STDs?
So we do have a sexual history, and it'll be in his social history.
Which is right here.
Mentioning particular things about his social history. So we had asked about well water in particular, and he had denied, or he had admitted to a lifelong history of drinking well water, so potentially some heavy metal exposures there. He had no exposure to pesticides, including no Agent Orange exposure while in the military. He had very little alcohol exposure. He admitted at least to like 1 to 2 drinks of alcohol every couple of days, and no history of binge use of alcohol. He had, however, been a heavy tobacco user for many, many years, but he had completely quit 3 years ago.
And sorry to keep asking questions in addition, but any bowel or bladder symptoms at all with this? I should have asked this earlier.
He denied bowel or bladder symptoms. He also had run his own auto body shop for a number of years, but was now retired. He lived at home with his wife. He has adult children who are healthy. And then regarding HIV and syphilis, he doesn't have a personal history of STDs. And he says that he himself, he believes he has no risk factors. He's been in a monogamous relationship for a number of decades. Regarding the family history, he did have a father who had passed away, who had a history of both cardiovascular disease with CABG, and he had a history of stroke as well. His mother had passed away in her late 70s, he says, of natural causes, but had a history of diabetes. And then he had no family members who had specifically neurological illnesses, nobody who had muscle disease, who had neuropathy, who had gait problems. He had also no members who had a diagnosis of ALS or Parkinson's disease.
So now that we're done with taking most of the history, we're going to move on to examining the patient. Is there any specific additions that you wanted to add to just besides the general screening of the exam, and what part of the exam would you like to focus on?
So the part where he just walks into the room with me, so the walking bit would be a big focus. What does his gait look like? And that may be able to tell you a little bit where to look specifically on the exam or not. But obviously, you do need a good sensory exam. You need a good motor strength exam, reflexes as signs of upper motor neuron, sort of differentiating that if there is weakness, and then ataxia, so cerebellar exam. Really everything.
So when the patient walks into the room, the first impression that I had is he actually looks very well. So he's a very pleasant, fully conversant, normal mental status type of person. Gives a very detailed and good history and very fluent in conversation. Now he is using a single point cane when he first comes into the clinic, but he can walk without it, and actually his gait doesn't look too bad. It's not remarkable for any specific dysfunction. Actually looks very good. However, we do have his motor exam where we start to see a few things that are unusual. In his right leg, he had slight weakness in the hip flexion and also knee extension and knee flexion compared to the left side. I rated it 4 out of 5 on the MRS scale on the right side, but 5 out of 5 on the left side, and really pretty full strength everywhere else, maybe slightly weak in his grip on the left hand. And he did have some wasting in the interossei muscles of the left hand as well. But otherwise, his strength was really pretty full throughout. And he had no wasting in the right leg either. Now, he did have very slightly increased tone in both legs, but it was fairly subtle.
And no cogwheeling with that, just increased tone, sort of more spastic.
It was more spastic. There was no cogwheeling. What really surprised me when I examined him, when I examined his reflexes, is that he had 3+ brisk patellar tendons reflexes, and he had sustained clonus at both ankles, and then his plantar reflex was upgoing. The Hoffman's was negative, and his upper extremity reflexes were really 2+ brisk symmetric. And then he had an intact sensation to pinprick in all extremities. Light touch was intact. Vibratory sense was reduced to about 6 seconds in both great toes. But he was actually, speaking of how his gait looked fairly good to me, his was actually able to tandem walk, and his finger-nose-finger seemed very normal to me, and heel-shin was also, although he had a slight difficulty, I think, because of the spasticity, it really was no ataxia or dysmetria on his heel-shin.
So based on the history and the exam, we're sort of categorizing this guy as having spastic paraparesis. I don't know if you agree with that, but just based on the history and the exam alone, where were you wanting to localize his findings?
So let me just maybe give one brief thought to that. So spastic paraparesis is kind of right. I think it's maybe important to note that it's asymmetric and that he does have something wrong with his hand as well. So it's not just affecting the legs, and he technically is not so weak on the in the left leg, right? But yeah, so myelopathy type picture. And I would probably most likely localize this in the spinal cord, but it could be in the brain as well. Brain stem, I guess, is our options. Given the reflexes, it does not really seem to be a peripheral nerve issue. And then the vibratory sense could be misleading because it could potentially be an additional thing that that's not the same process, but it doesn't seem to be a muscle issue either.
So he does have a little bit of atrophy in his left interosseous muscle. Do you think that it's just a red herring, or is it something that it would fit in with the myelopathy picture?
It could fit in with myelopathy. It would make me think that it's not necessarily localized to the thoracic spine.
At the time, we had kind of, I had felt that the left hand wasting was more likely like an ulnar nerve peripheral thing. So we did pursue
distribution.
That was how I felt it was in clinic, and we pursued a workup for a myelopathy at that time.
Any kind of, based on this, then any kind of labs you want to do, any imaging, or what would be your next step?
So there's a number of things that I always want to exclude if someone presents with a probably more myelopathy picture that are treatable things especially. So Vitamin B12 is unlikely to be completely responsible for this, but I would like to check that. Since we don't know what's going on, I would probably do a more extensive workup and include things like syphilis and HIV despite the negative social history. I would want to maybe do copper and probably do just a general CPC and chemistry panel to see if there's any sort of concern for sort of a more systemic process. I didn't ask that, but he didn't endorse any other symptoms that would make you worried about a more generalized process, it sounds like.
So the review of systems was really negative,
Yeah.
pan negative.
And then the other thing that you could do as a second step potentially would be things like a rheumatologic workup, so ANA, or less likely in this patient, he's Caucasian, or
He is Caucasian.
a little bit less likely to be sarcoid, but it might be worthwhile, or you could wait for imaging at that point.
What kind of imaging would you be thinking?
I would probably want to do an MRI of the cervical and thoracic spine. The cervical because it's not clear what's going on with his hand.
Starting with the imaging, we actually chose to image only the thoracic and lumbar spine, and both of those initial studies were completely unremarkable as reported by the radiologist. So you already kind of answered this question, I think, about the selection for cervical spine imaging.
Yeah, and I would probably not have necessarily done a lumbar spine because I would not expect sort of increased reflexes with more peripheral sort of more nerve root issue with the lumbar spine. But obviously he had low back pain, so it's reasonable to do that. But I probably would have started with the cervical and thoracic spine.
And would you have still done the cervical spine if he hadn't had the left hand wasting?
I might have just done the thoracic spine and started there, and if that's negative, done the cervical spine. Depends a little bit on logistics too at that point. How quickly do you want to get the workup done, and how far is the patient traveling, and things like that.
We have a list of the labs that we did. Many of them are ones that you mentioned. So
yeah, HLV is very important too, yeah. Thank you.
And really our initial workup was negative, so infectious workup with HIV, which can cause myelopathy, especially with the posterior columns, the RPR, HTLV, B12 and MMA, which I think we may have expected to see more of an encephalopathy with those, vitamin E and copper, which you mentioned. And then we also decided to send a paraneoplastic antibody panel. I don't know, you didn't mention that one. Would that be something that you would send to first line or maybe later on?
I probably would not, unless there is no sort of more simple explanation to be found.
After those labs and basic studies had come back negative, we did touch base with the patient to update him. He was now beginning to feel more progression of his symptoms, where if you recall previously when he was seen in clinic, he had said that he'd been at a plateau for a number of months. But he did think that it was getting a little bit worse and that he was really having to make a conscientious special effort to lift his legs up to get over small barriers.
Bilaterally.
Bilaterally, he's thought. And then he was having more difficulty with standing as well, multiple attempts to get up from his couch or from a chair, for example. So the question is, did he have bowel or bladder symptoms? And no, he had really denied bowel and bladder symptoms on his initial visit. He said that he had the typical aging male, maybe having to urinate more frequently, but otherwise he felt like he was normal. So he also endorsed a tendency to drift to his right when he was walking, and he had to conscientiously steer himself back to the left. He also thought that he was having increasing muscle twitching in the right leg, which was relatively new over the last few months.
Where would the muscle spasms trigger any thoughts in your mind?
It would still make me more worried about CNS etiology.
And at that point, would you think that an EMG would be indicated maybe more because of the muscle twitching, or would it not have?
I mean, it depends a little bit on, I guess, the description of the muscle twitching. If it's really sort of spasms in the legs, then I would not think peripheral at this point. And with the increased reflexes, I would I would probably not have done that as a next step. It's fair enough, like I said, the vibration sense loss could be a red herring, and so it could be upper and lower motor neuron picture. So getting an EMG to exclude that is not unreasonable. I probably would have not done it at this point, but I understand why you would do that.
Okay. So an EMG was added in between his first and second visits after the initial workup had come back negative. The EMG was fairly unrevealing. He didn't have any electrodiagnostic evidence of either sensory nerve or motor nerve or muscle dysfunction. So a very negative study, but I think it was helpful in some ways to rule out something like ALS.
And again, it depends on what these muscle spasms are, and sometimes it's hard to get from a patient. Are they like really bigger spasms, or is it sort of fasciculation type picture?
So the patient came back for follow-up, and in the interim, he actually had gone to the emergency room because he felt like he was developing a UTI, and they actually did a bladder scan and discovered that he had 1.5 liters of urinary retention. So what he had thought was maybe some very benign urinary symptoms turned out to be urinary retention. So he had very significant retention requiring catheterization.
So, given all these new informations, given all these new informations, and what additional testing will you want, and what kind of differential do you have in mind now? Does it help narrowing down anything?
I think it all still confirms me in thinking it's a central nervous problem, and I would definitely want a cervical spine MRI,
Okay.
especially with the bladder issues now.
Okay. So just the cervical spine or any other imaging?
Right now, I would do the cervical spine. I haven't heard really anything on exam or on complaints that really makes me think about the brain. If the cervical spine MRI is normal, I would also do the brain.
Okay.
So again, you could be conservative in conserving resources, or you could try to speed things up. Sometimes that's a logistic question.
Yeah.
We have a question.
Before you mentioned that the lumbar and thoracic spine was read as clean by the radiologist. Did any neurologist also look at the film?
So we did look at the film, and it was pretty unremarkable.
And was the thoracic spine MRI done with contrast or without?
The thoracic and lumbar was done with and without. So we actually added a brain and C-spine, but we added them without. We're going to show you the brain MRI first.
Okay.
What are your initial thoughts on these images? These are just representative.
Yeah, so he has some white matter disease, periventricular, around the ventricles. I mean, that's something that I could see. It's not the most extensive I've seen, but it's also not nothing. It's something I could see in hypertension, sort of a vascular picture of smoking history. One of the lesions on the left scan here, is a little bit, not on the other scan, on the MRI defined left side, is a little bit less typical maybe for sort of a vascular thing, because it's a little bit more, it's not quite juxtacortical, but it's a little bit more away from the ventricle. But still, all that is something that I could see in someone who has hypertension and smokes. And I don't know that this explains his walking, just to say that too. Okay, this is a little bit more interesting. So these are T1 images, and he has some black holes, it looks like. So the MRI here shows some T1 dark structures.
Maybe lights in the front down. That helps a little bit.
So let me actually see if I can do this. So here, this is sort of the last bit of the ventricle, and then here there are some dark spots on this T1 image. So there's some T1 hypointense spots, something in the back here as well, that is something that we would, for example, see in someone with MS. Let me see the other images. It's hard to see. I don't see that, and that's not a. I don't see that on the other picture. But so the sagittal image here shows some perpendicular to the ventricle, some sort of black holes, T1 hypertense lesions, which, yeah, does not necessarily mean MS, but makes me think about that.
Okay. The other thing that I was wondering a little bit about is that temporal pole in the other image. There's a little bit of flare hyperintensity there.
Yep, that's a little bit odd looking, actually.
And we did acquire an MRI of the cervical spine, which we can show next.
Hard to see.
Do you want to look at
Sorry,
it
you
from
can
this-
actually, if
yeah,
you'd like
if
to
you
look
want
at
to
the laptop.
this one.
So we have the radiologist report, quotation from the radiologist
Yeah,
here.
there are actually some lesions here. It's hard to see on the screen. It's a little bit easier to see here. So I think here, and it would be good to, and here as well, it would be good to have axial cuts as well, because spine MRI is a little bit hard to reach if you just look at one type of image instead of having two ways to look at them. But it seems to me that there's some signal abnormalities in the cord. He does have a little bit of degenerative disease, but it's not impinging the cord. It's not. It seems, at least on this one slide, that there is enough room for the spinal cord, but he does seem to have cord lesions that are really hard to see on this screen. What was the radiology read?
So they did read it as having diffuse cord signal abnormality with areas of myelomalacia as well.
Can I ask a question? You had one cut of his CNS films on his brain MRI through the optic nerves. Were the optic nerves felt to be normal?
So there was no atrophy of the optic nerves on imaging.
And no signal?
And no signal changes in the optic nerves. And that was a question from Dr. Ransom. So, I think that what our thinking at that time was, because the radiologist had read the image as being consistent with multiple sclerosis, was we thought that it was clinically a very odd situation for MS. And the patient, reminder, is a 58-year-old man with newly presenting symptoms. His only clinical symptoms really are we thought the slight weakness, increased tone, and increased reflexes of the lower extremities. And does this really kind of fit that picture? And we do have a question in the back. So the question is about NMO antibodies, and we do have the next phase of his workup coming up, and that would be something that we can talk to Dr. Von Geldern about.
Somebody has a question too.
I'm just going to confirm it. So he's never had a contrast enhancing lesion.
So the question was about contrast enhancing lesions, and he did not receive contrast for the brain or cervical spine MRI. So no contrast enhancing lesions could be seen at this time.
Do you want me to comment on your thoughts at this point?
Does it change your thoughts at all?
No, I mean, I'm not surprised that he has issues in his cervical spine. I think just from this, just having one image to look at makes it a little bit harder, but I understand why the radiologist would read this as typical for MS, in the sense that it's not longitudinally extensive. Again, you can't really see this on the screen, but it's not longitudinally extensive. It would be nice to see axial images to see if it's affecting the entire spine or just a partial signal abnormality, which would be more typical for MS. So in MS, you would expect not the entire sort of diameter of the spine being affected, but just typically not central, but sort of more, partial signal abnormality. But that is certainly an MRI that we see in MS. You're right, the clinical history does not give you the typical relapsing remitting.
And I can tell you that while we don't have any axial images to show today, that the patient did have a paracentral partial cord signal change. We wanted to show this graph of the typical age distribution for MS, since MS had been raised as a diagnostic possibility at this point. Again, I think this graph kind of shows that while there are cases reported in this age range, it's pretty uncommon, with just a very few people diagnosed at that age. And this graph does come from the Bradley neurology textbook.
Questions, when was this done? Because the other thing too, I think this diagnosis of MS has changed a little bit in the sense that before there were treatments, people were not diagnosed as often as now because it didn't matter so much what you would call it. And then sometimes I think primary progressive MS is not diagnosed as much, again, because there are not that many specific treatments. So that can impact reports of diagnosis. Yes.
We'll go back to that slide. I would probably say that this, no, the other one, yeah, that this is for relapsing remitting MS, that this is the age distribution, because the patient sounds like he has primary progressive MS, and 50s is a perfect age for that disease.
So the comment from Dr. Kraus was that this graph likely represents relapsing remitting MS because 50s is a good age for diagnosis of primary progressive MS. So at this point, we just want to ask the audience what you think.
So do you guys feel like it's more demyelinating disease, or is it more mimic of an MS? Or if anybody can hear me.
If you think that it's this is a primary demyelinating MS, disease like MS, like the radiologist suggested, can you go ahead and raise your hand? And if you think it's B, mimic of demyelinating disease, also raise your hand. So it seems like a majority favor that it could be multiple sclerosis as the primary etiology.
What other differential?
And so I raised my hand saying that I think this is a mess, but having said that, I love that you're asking this because I think this, not amongst you, of course, but in general, I think a frequent misconception that you can just diagnose a MS, and the most important part of diagnosing a MS is to exclude other etiologies. And so you can never know until you really think about it and make sure that there is no mimicking other cause. So I think I would now want to go back to him and actually ask him some more detailed question, making sure that I have a sense of, is there something else that could look like this? So does he have now, or has he ever had skin rashes, joint pain, problems with breathing, other sort of systemic issues? So I'm thinking about more rheumatologic diseases that are rare, but that could certainly look like this as well.
So he's never had joint pain other than related to injuries, and rashes. He's maybe had 2 small rashes of his extremities in the last 10 years, but no significant rash problems. Really, again, as far as his rheumatological review of systems goes, it was remarkably negative. Any other questions that you'd like to add to his history?
It would be, I don't think this looks like NMO at all, and someone with NMO typically always presents with a sort of more acute presentation and much more severe weakness with a spine presentation, but I would probably want to ask about vision, not necessarily for NMO, but also sort of to get a sense of that. And the other thing I would want to really make sure that I ask it again is, has he ever had any sort of symptoms that resolve, neurologic symptoms that resolve? Sometimes people don't pay much attention to it, especially guys, and sort of want to make sure that he didn't have numbness that lasted for a week or 2, or vision changes or things like that.
So
I had a question for Dr. Van Geldern. So are there any MS mimics that would produce black holes like you saw in this gentleman's MRI?
That's a good question. It's the black holes are not specific to MS. They're not even, but you wouldn't see them with vascular disease. So you could potentially argue that a lupus-induced lesion or a sarcoid-induced lesion can also leave behind axonal damage and therefore produce a black hole. So you do see that. Those are obviously very rare, but I don't think the presence of black holes excludes mimics necessarily, like rheumatologic or other sort of demyelinating maybe diseases that are not MS. Yeah.
And I like your comment about NMO being acute, as is lupus myelitis being acute. I mean, it's a slowly progressive disease over 3 years. Doesn't sound like rheumatologic.
Well, I think the problem is that some of the rheumatologic conditions can present in very different ways. A lupus myelitis maybe doesn't typically look like this. Sarcoid I've seen be a lot less sort of acute. Yeah, Sjogren's sometimes as well.
And the comment was that oftentimes autoimmune diseases seem to present a little bit more acutely. So we did ask the patient pretty extensively about his past neurological symptoms, especially vision, and he denied episodes of vision loss, so no discrete vision loss in either eye had ever occurred for him. He thought that maybe his eyes were getting a little bit worse with age and having more difficulty reading, but he had not been to an eye doctor in a number of years to have his eyes checked. He denied any episodic motor symptoms. He did say, however, that maybe 2 years prior he had fallen on his arm, and at the time that he fell, after he fell, he developed some right arm numbness that persisted for somewhere between 2 to 3 weeks. He can't recall now, but he thinks it was linked to the fall, and it went away, never recurred. And that was really the only sensory symptom that he had, and really those are the only kind of positive things that he mentioned. So at this point, this is the differential diagnosis that we had put together, and after seeing him twice in the clinic and obtaining that MRI, we actually referred him to our VA MS center. So I'd ask you to comment on this, but before I do, Dr. Ma has one question.
So was there ever any cognitive testing and even a MOCA exam to verify that his cognition is completely normal?
So he never had formal neuropsychiatric testing or memory testing in the clinic. You know, the basic neurological testing and history was very good and clear for him. So we never proceeded to MMSE or to a MOCA. And to my knowledge, he has not yet had any type of neuropsychological testing.
Can I just add one small point? A while back, maybe 10 or 15 years, neuromyelitis optica was quite a pure thing. You weren't supposed to have CNS lesions beyond spinal cord and optic nerve, and a bunch of them would put you off that diagnosis. Now we have neuromyelitis spectrum diseases, which can include all kinds of things, including central nervous system disease, a very slow progressive course. And I just mentioned that because although it's not specifically on this list, I wouldn't absolutely eliminate it.
So the comment from Dr. Ransom was that although historically neuromyelitis optica was considered to be a condition affecting exclusively the optic nerves and spinal cord, more recently it's been recognized that there's a spectrum to that disorder, which can include cerebral lesions as well. And Dr. Van Geldern, I don't know if you have any comments on the list that we put together here for a differential diagnosis.
I think some things on the list are much more likely than others. So I don't know really that I would have primary lateral sclerosis on there, given the imaging findings. The spinocerebellar disorder also, I think, is going much down the list for me. But yeah. I think Caddisol, I shouldn't speak in front of you, but I wouldn't expect the spinal lesions.
If you had symptoms for 2 years, then why would you consider ADEM?
So the question is, would you really consider ADEM if you've had symptoms for 2 years? And I think the answer is that you really wouldn't consider ADEM as being a progressive, as being a progressive condition. You're right.
So given all this, what kind of imaging or what other study would you like to do where you just feel comfortable saying this in MS?
I would get a few more blood tests, so I would do ANA screening, and I don't know if I would do necessarily much beyond that. You could do an ACE test if you were concerned about sarcoid, which is very unlikely, but I would tell the patient that I'm concerned about MS. He does actually technically fit the criteria. Well, yeah, he's had symptoms for 2 to 3 years. Yeah, he does technically fit the criteria for progressive MS. If the patient, depending a little bit actually honestly on the patient, if the patient wants to have more diagnostic certainty, I might consider an LP because the presence of oligoclonal events or an elevated IgG index would make me much more confident. Not that that's 100% test either, but that would fit well, but it's not needed for the diagnosis. He does fit the diagnostic criteria for primary progressive MS already.
And that's actually one of the questions that we have, is it now that there's a change in the diagnostic criteria for MS, and under what situation will you be considering to getting an LP?
So that's a more general question that looks very different in a more relapsing remitting clinical course. And I think the situations where I get an LP is if I'm not sure, because it's a very equivocal picture. So in primary progressive MS diagnosis, I might think about that more just because it's a diagnosis that is less common than relapsing or remitting MS, often patients really struggle with that diagnosis because there are no very good, strong there's not good, strong evidence for any treatment being effective. And so a lot of times I find that patients really want to have more certainty and really want to be convinced that that's what's going on. And so I might, for that reason, do an LP to have more evidence. In the relapsing or remitting presentation, I think I might do it if someone has, I might do an LP if someone has sort of one initial symptom, sort of a clinically isolated syndrome, and they want to know more about how high is their risk, because if they do have oligoclonal bands, that increases their risk of developing MS compared to if they don't. So those are typically situations, or if it's really not clear.
Zia has a question.
That's on the client progressive MS point. Would you consider documenting whether the episode of numbness that lasted for, could this be an episode? I mean, that's a bit confusing in the sense of feeling and about client progressive with this episode.
That's a great question. The question is, what do we do with this one episode of numbness? And that's hard. Could he have had a relapse and now a more sort of secondary progressive course? I think it's really difficult if it was temporally closely related to a fall, and it's going to be really hard to retrospectively know where the numbness was and exactly what this was. It's possible that this was a relapse.
And the reason why it's important because now with the PARAPARESIS study is talking about papilizumab being helpful for primary progressive and this can be changing.
So I'm not entirely sure how helpful that differential is. I think from most of the experience that we have in treating MS, in my mind, the main differential is does someone have a primarily, and I don't mean primary, but mainly progressive course versus a mainly relapsing course. The reason for that is I think that treatment, so the disease-modifying therapies, autoimmune changing or immune modulatory treatments mainly work for the inflammation part. So they mainly work for patients who have a relapsing or remitting course. They also probably work for the subset of progressive patients who have still immune activity. So someone who has a secondary progressive MS but has enhancing lesions, I would say might benefit from disease-modifying therapy. And so in my mind, it's not so crucial whether it's a primary or a secondary progressive MS, even though primary progressive MS makes me less optimistic about the efficacy of disease-modifying therapies. But I think it's more important that right now, for the last 3 years, he's had progressive course. And so unless I see enhancing lesions or clear sort of clinical up and down in his disease course that makes me think of sort of maybe on top of that he's still having relapses, I'm not very optimistic about disease-modifying therapy being useful. And so at least the current available ones. So I think I tend to think more of this is a progressive and this is a relapsing case rather than it doesn't matter so much, I think, in my mind, whether it's secondary progressive or primary progressive, other than someone with secondary progressive disease might have more chance of still having a immune activity component, if that makes sense.
The episode of numbness, was that on the same arm as the atrophy that you found on the exam?
That's a good question.
So the question was if the episode of numbness was in the same arm that he now has atrophy, and the answer is no. The numbness was in the right arm and the atrophy was in the left arm.
Was that when you let the diagnostics?
And second part of the question was, did the EMG evaluate the left arm? And no, it did not. It was the lower extremity EMG only.
That's another question.
But if he doesn't have numbness in his left arm, it's not going to be an ulnar etiology. And he certainly has disease in the level of C8T1 that he could be getting some of the roots coming out of the lower motor neuron and getting atrophy in his hand. So you haven't excluded MS being the cause of his atrophy in his left hand.
And the comment was that he doesn't appear to have the appropriate clinical symptoms for an ulnar neuropathy in the left hand, and he has the appropriate myelomalacia in the lower cervical, upper thoracic, spinal cord area that would correlate with his atrophy, so that MS could potentially, if that was the diagnosis, explain the left arm symptoms.
I have one more question, actually. Getting back to the LP, what's your pre-test probability that it is primary progressive MS?
Hi.
Hi.
And so, again, I think it's medically, I feel confident in calling it primary progressive MS. But I think it can, and maybe that's not right, but I feel like it can be reasonable to offer this to a patient who's very disconcerted and unsure about the diagnosis.
Being an invasive test, it's always hard, and
That's true.
With relapsing remitting, the sensitivity is 85–90%. For primary progressive, it's down at 50%, right? So that it doesn't seem like the answer to whether he has oligopolar bands or not should change your thinking if your pretest probability is so high, and could just make the patient feel less comfortable
With the diagnosis. That's true. That's true. I have to double check on that. I thought actually it's a little bit higher than 50% the presence of oligopolar bands in primary progressive MS. That's obviously not studied that well because it's smaller numbers, but it is part of the diagnostic criteria for primary progressive MS. So it's I think it's brain lesions, spine lesions, and or evidence of oligopolar bands or IgG index elevation and CSF. So it's true if it might not be necessary to do an LP, and I wouldn't feel strongly about it. But
Dr. Roxy.
I guess just one other point, you maybe already made this, Gloria. It's not just to fit nicely the formal criteria, but this is kind of a classic presentation, isn't it? This sort of difficulty with walking.
yeah, sort of a few faults, like tripping over his feet, going down. I completely agree, and I haven't made that clear. Maybe it is a very, thank you for the comment, it is a very typical presentation of PPMS.
So he did undergo a lumbar puncture, and we have the results here. So we did this at the VA. So the protein was elevated, but glucose and leukocyte count was normal. Oligoclonal bands were actually negative, but there was an increased IgG index and IgG synthesis rate.
Okay, can I retrospectively agree with Dr. Krause that it's not always helpful to do a test that might be negative? I wouldn't be swayed from still thinking that this is a mess. What concerns me a little bit, and does he have diabetes? I don't think he does.
No, he does not
What
have
concerns me a
diabetes.
little bit is that his protein is very high, so that can be a sign that he has sort of more degenerative changes than I was aware of maybe, but that's not necessarily a typical finding in MS to have such a high protein.
I'll just take the other side on the LP. And I have the couple people I've had who I thought are primary progressive, I have LP, and I've been a little luckier and gotten positive. I think
Me
it's
too.
something you have to at least talk to the patient about. I mean, it depends on the patient's level of sophistication, that there is another diagnostic test that you could get. It's hard, I understand, it's hard for patients to understand that negative doesn't mean you don't have the disease, but I think it's a conversation you should at least have. What do you think about the IgG index?
That's a synthesis rate, though.
This is a synthesis rate, which I'm not sure what the normal range at the VA for that is.
That one is quite elevated.
Yeah. I mean, people can have simply just elevated IgG index or synthesis rate and not have oligoclonal bands. It also depends. I don't actually know where do they send the oligoclonal bands? Where is that done? You know? Is that done at UW? Okay. So without offending anyone, the UW lab is not incredibly sensitive with their oligoclonal bands.
Gloria, question for you. other thing about imaging that struck me was you seem to have a bit of volume loss. Does that help you at all in making that diagnosis?
You meant in his brain that you thought there was some volume loss. I don't think that's necessarily very helpful. So he has other reasons to have volume loss. He could have volume loss because he is older, slightly older, because he has smoked, because he has hypertension. It's certainly something that we do see in MS, and it can be a predictive factor for people who in the future will not do so well, but it doesn't necessarily help with the diagnosis, I think.
So we also obtained visual evoked potentials for this patient, which are shown here. The visual evoked potential was read as being markedly abnormal bilaterally, which I think, considering the imaging, is really not too surprising. But we also sent him to ophthalmology for a dilated fundoscopic exam, and they noted that there was mild optic disc pallor on both eyes.
Pallor or swelling?
He had both, actually, pallor and a little bit of.
So why I am frowning here is that swelling is a little bit surprising to me, because that would more indicate a current acute sort of inflammation or something else going on. Optic nerve pallor or atrophy is something I would maybe more expect sort of chronically. So that's a little bit interesting. Was it on both sides?
It was bilateral.
Oh, okay.
In addition, his color vision was down with, the color plates are shown there, 4 out of 14 in the right eye and 9 out of 14 in the left eye. And would you have ordered a VEP for this patient? Or when do you order it for your MS patients?
I probably would have not ordered a VEP in this case because I'm not sure how much it would have changed my thinking. What I sometimes do, and that's the luxury too of that you don't have so easily at the VA, is it can be helpful if someone has visual complaints to send someone to neuro-ophthalmology rather than doing a VEP, because they can do additional things like give you OCT and other things. So, but I would have probably not ordered a visual potential here.
Okay. Would you have done a CD8-CD4 ratio given the protein? Sorry.
So the question was, would we have checked a CD8-CD4 ratio?
When to start going back?
Yeah, possibly. Yeah. Yeah. I definitely would have done an ACE. Or at least done, and I might even, yeah, not just based on the protein, but yeah, it does make me a little bit more thinking about sarcoid. That's a good point.
So we have a few additional tests that were done in the results here. And the ACE was normal. Several of these, I think, may have been low pretest probability tests. Are these tests that you order with any frequency in the MS clinic to rule out mimics, or how often do you check for
Not
these?
with high frequencies. So not 3G and thinking about Cadazole, I would have not done because of the spinal cord involvement. I do occasionally order all of these, but probably rarely.
A few additional, he was screened for TB, screened for Lyme, also the rheumatological workup, it was all negative. Just to follow up on additional imaging that he had later in his hospital course, this time he did have gadolinium administered with his MRI, and it did show one small enhancing lesion, periventricular, and I think that this more recently acquired flare was also more interesting.
Mm-hmm. You didn't show us a sagittal flare before, I don't think, but this is a lot more extensive than before, I'm assuming.
So, I guess putting your money down, what do you think would be the most likely diagnosis, and what is the the strongest evidence that supports your decision?
I think he has multiple sclerosis based on the fairly somewhat typical clinical history and the imaging findings. And I am especially convinced by the cervical spine MRI. Given the contrast enhancement and the what was the difference between the two MRIs? That was not very long, right? Between the two MRIs? 6 months. Given that he has a significant increase in his lesion load in only 6 months, I would maybe pay a little bit more attention to that numbness episode and not be 100% sure that's definitely primary progressive. I do think he has progressive MS, but I think that I'm more optimistic that he has an inflammatory component, and that would matter in the sense that I would potentially consider at least discussing disease-modifying therapy.
Okay, so he was given a diagnosis of probable primary progressive MS at the VA MS Center.
And I think we are all in MS centers tend to be a little bit more careful with primary progressive MS diagnosis. So it's called probable, but he does clearly meet the full criteria for it. But because it's less common and you don't want to be wrong, maybe people are a little bit more careful with that. I don't know.
Could you give us a one or two phrase overview of what is typical for primary progressive MS? What does that look like? I have a few statistics up here on the screen.
Yeah, so actually that your patient is not atypical at all. Most common clinical presentation of primary progressive MS is progressive gait impairment. Patients tend to be, like Dr. Krause already said, tend to be older than in relapsing remitting MS. And unlike relapsing remitting MS, you have that on here. It's not a predominantly female, but it's more one-to-one disease. And yeah, you did say that the spastic paraparesis is pretty common. So yeah, the gait impairment is typically the first symptom, and it's usually insidious and fairly slow.
And I included this chart from a Lancet review paper of primary and progressive MS, where they mentioned many of the same things, especially the motor much greater than sensory involvement. There was one question that I had for you, which is that in the chart that they say that there's prominent cortical demyelination later in the course of primary progressive MS, and I was wondering if you could kind of clarify what they mean by that, and is it affecting our patient based on the very few images that you had looked at earlier?
So cortical demyelination is a fairly relatively new concept. So obviously we think of MS as a demyelinating, meaning myelin affecting, meaning white matter primarily affecting disease. We have recently found that a lot of the sort of lesions and plaques are not just in the deep white matter, but that if you look in more detail with better scans, you also find that in the cortex, you probably actually can't see that very well on these types of images. So that's more commonly in sort of at least at 3T MRI. It's easier to see if you have additional specific sequences, diffusion tensor imaging, things like that. Yeah, cortical demyelination is something that we are just more recently aware of, I think.
Just a few last questions. Would you have considered any treatment for this patient?
So when you got to the second MRI, he had enhancement, and he had sort of also reported, I think that was around the same time, some worsening. I do think in a new diagnosis of MS, it would be reasonable to treat with a course of IV steroids, because there seems to be at least some inflammatory component, and it would be helpful to see if he responds at all to that. So that's probably something I would have considered in this case. For the same reason, because there seems to be an inflammatory component, I think it's a discussion to have, weighing sort of benefits and risks, that disease-modifying therapy is not unreasonable, at least a trial, keeping in mind that I have a low threshold of saying, let's see how you're doing without that, if there doesn't seem to be any sort of, or not improvement, but any sort of slowing of the disease course. And for that reason, I probably would lean towards a safer DMT rather than a more aggressive side effect rich DMT.
Okay. Well, the patient did not receive steroids, but he actually was put on dimethyl fumarate, which he was on for some time until he developed lymphopenia and was taken off of it. He was also put on vitamin D and baclofen, and actually...
If he hadn't already quit smoking, that would be very important to attempt to quit smoking.
Yeah, yes.
Zia has a question.
So, so would you consider, given the new studies that, or a current study that just came up, talking about eculizumab, would somebody tries to get them the drug, or so what does our stand at us?
Yeah, so it's a good question. So there is some small initial data that maybe eculizumab is helpful for primary progressive MS. You can't really get eculizumab at the moment outside of a trial. Rituximab is a related medication. It's really this sort of same target of CD20 antibodies, and I'm a little bit hesitant to be super excited about the data on eculizumab because rituximab has not been shown to be helpful in primary progressive MS, and so I don't think that a drug with potential significant side effects that I'm not clear on the efficacy, I would start with outside of a trial. It would be a very different discussion to say this is someone who wants to be in a trial, but I would not off-label try to get a medication that I know I couldn't get right now, but that like eculizumab.
What about, I can't think of the name of the drug, but there's a drug that's expensive that people sometimes just use for gait in primary progressive.
So yeah, that's a good question. And we are just talking right now about medications that might affect the disease course and slow the progression or halt the progression of things like that. So thank you for bringing up Ampyra. So Ampyra aldefrin is a medication that is a symptomatic treatment. And so that we haven't even talked about at all here, except for the baclofen, which is also a symptomatic treatment. So I think symptomatic treatment is incredibly important. Ampyra is a great medication. It's changing potassium channels, and because of that, making sort of transmission of signal from brain to extremities. It's been specifically tested for lower extremities and walking and gait easier and faster, and so it can be very helpful. It's only beneficial in about 30 to 40% of patients, but that is definitely worth a try. The efficacy of this medication is usually best seen in people who have probably more impairment than this patient already has at this point. So people who have really a visibly slowed walking speed can benefit quite well from this. Main risks are seizures. So someone who has had a seizure before, I would not put on this, and someone who has an impaired renal function also should not be on this because they have an increased risk of seizures. But yeah, so symptomatic treatment, very important in here, can be a great medication. I think I would give him, or talk about AFOs in him as well. So ankle foot orthosis, if he's like continuously tripping over things, can be very, very helpful as well.
Well, thank you very much, Dr. von Geldern. I just want to I want to conclude by saying that I spoke to the patient this week, and he says he's doing very well, really not progressing very much, and is overall very satisfied with the low rate of progression with his disease. Dr. Linden and I both wanted to thank you for being so generous to come out here and let us ask you so many questions and really put you on the spot. But we've, I think, learned a lot from you about the workup for this kind of patient, and we greatly appreciate it. And as a token of our appreciation, we did want to present you with a certificate for coming here today to Grand Rounds. So
thank you.
Please take that.
Again, I did not.
We have Dr. Wanda who provided us with the very, very nice pictures of her.
And a round of applause for the residents. Very
yes.
nice.
Congrats.